get started. I'm Alice, I'm one of the surveyors, and I'm on the training team, and Brian is back here also, and he's passing out the cards for you. And we will go ahead and get started. We will get started. We are going to go ahead and try to videotape even though our audio isn't working right now, and hopefully it will kick in for us. Alrighty, so this is a map of the strategic plan for the Department of Health Services, and one of the main goals is integrating physical and behavioral health services for all of our clients. No longer keeping them separate and segregated, but to be able to have the whole person looked at, both for physical and behavioral health services. Okay, integrated rules for institutional licensing. House Bill 2634 was put in. That's an order for July 1st of 2013 to have these rules updated and implemented. Well, a little bit of struggle, as you can tell. We're into September now. It's going to be October 1st will be implementation date. And the reason for this is to hopefully streamline the regulation process, to provide services, like I said, kind of a one-stop shop for clients, so they're getting both their behavioral and their physical needs met in one location. Some of the articles and rules are going to focus, well, the main focus is going to be health and safety of your clients. Provide regulatory consistency for all healthcare institutions, again, to streamline the process and to integrate the services. The rules are now going to be policy driven by you, by your agency, and no longer mandated by specific things that we told you. There are going to be obviously rules you have to follow, but it's up to you on developing how you're going to follow them. So the integration is the license based on the highest level of services that it provides. You'll be able to have a menu of services. You can choose from a list that we will see as we go through here, different services that you can provide. Residential will no longer be broken down by a level 2 or level 3. You will simply be a residential facility. Then you choose whatever it is you want to do. Counseling, assistance in self-administration, medication, personal care, med services, any of those types of things. All of your med services will be directed under, will be provided under the direction of a physician, and nursing services provided under the direction of a registered nurse. Your behavioral health services provided under the direction of a licensed behavioral health professional or psychiatrist. Your BHTs and BHPPs will receive clinical oversight or direct supervision from a BHP. And we will go into this but more when we get into definitions and more into the article. Okay, the timeline, the rules were actually filed with the Secretary of State on June 28th, and the implementation will start October 1st. We've had a couple other trainings in the past week for outpatient clinics and for inpatient. This is our first one that we've done on residential, and medical will also be having some trainings as well. And those are in September. I want to say 16th and 17th. So what does this mean to you? Again, you will need to start following the rules beginning October 1st. So I encourage you, read through the drafts, or not the drafts, I'm sorry, the unofficial rules. They're no longer drafts. Read through those, start figuring out how you're going to implement them, start educating your board, your physician, your staff, anybody that needs to be aware of this and what they need to do to follow those rules. Things that have changed, some of the content, definitions, there's a few additions, interpretations. Obviously the article numbers have changed. We're no longer R920. So if you have R920 something listed in your policies and procedures, you're going to want to get rid of those. R920s do not exist any longer in residential homes. A few of the things that have changed as well is the use of vocabulary. We used to say client. Now for residential agencies, they are residents. So for more information, like I said, Brian did pass out that card, and if you didn't get one, we will have more again when we take a break that you can pick up, and you can go on to that website. There are several resources on there, frequently asked questions, flow charts. There are some various videos and PowerPoints that you'll be able to click on and take a look at. You can review this one again if you need to. When we get into the section where we talk about quality management programs, that will be listed in there as well. So there's a lot of information, and this website is kept updated, if not more, at least weekly. Okay, end of slideshow. Now, we are going to start. Brian is actually going to go over Article 1, I believe, which is going to be formerly known as the Universal Rules. So Article 1 is your general rules. We have definitions, this is where we start. So a lot of the definitions are similar, and so not all of them Brian will go over, because not all of them are going to apply to the universal rules for all the healthcare institutions. So clinics who does hemodialysis, outpatient clinics, inpatient facilities, all of that. So I will just turn it on over to Brian.
All right, I'm sorry, I didn't mean to run out. On Friday, we got determination that the official rules as they're posted now are going to be the rules. Okay? So you can print them. Article 16 is the one that still is being totally rewritten. So for Article 16, which is the respite houses and the old adult therapeutics, don't print those yet. Okay. Now, as part of kind of going through this, we're not going to go through every definition. We're just going to hit some of the highlights. As we go through it, though, if you have questions, that's why we're opening up the hour and a half at the end, so that you can get some confirmation. So for all of you, you're all going to be in Article 1. Okay? Those are the general, kind of like the old Article 1. This is where you're going to find the initial application process, the renewal application process. We're still currently working on what that process is going to look like, because we have some new things that we're going to be doing in ADHS, such as approvals. Those processes are being worked on as we speak. So as you get closer to October 1st and you start looking at your licenses, just make sure that you understand that if you're going to be doing anything after October 1st, there's going to be new forms, potentially new processes when it comes to all of that stuff. The application itself is going to require more information on it, because we're requiring less information that you actually have to submit as part of your application. So we'll go through what that's going to entail, what some of the new terminology is going to be as we go through. Now, the adult behavioral health therapeutic home is what used to be the adult therapeutic foster care. Okay, so there is a definition here, but it's being rewritten as we speak. So if there are folks in here who are thinking about doing this, just keep in mind that we'll have additional information posted as we go through all of this. We're going to focus primarily then today on the residentials. Okay. So some of the terminology is going to be the same, but some of the definitions change. So assistance in the self-administration of medication means restricting the patient's access to the patient's medication and providing support to the patient while the patient takes the medication to ensure that the medication is taken as ordered. You're going to see there's no client. Okay? Everything now is going to be patient/resident. Okay? Available means for an individual the ability to be contacted and to provide an immediate response by any means possible. Okay. Now, as for equipment, supplies physically retrievable at the healthcare institution, and for a document retrievable so you can see as we scroll down, you're still seeing definitions for what a paraprofessional is, what a professional is. And we're going to get into more detail because that's actually in the article. Okay. And you'll see outside of Article 1, all of the residentials now are going to fall under Article 7. Okay. And in those, it tries to be as inclusive as possible. So, you know, in the past, when you looked at Article 1, Article 2, Article 3, and Article 4, and the current rules, they kind of bounce you around within those four. Our goal when they wrote those was to just give you one set of an article that you have to follow. Okay? Now, a behavioral health residential facility means a healthcare institution that provides treatment to an individual experience a behavioral health issue that limits their ability to be independent or causes the individual to require treatment to maintain or enhance independence. Now, this is the other home that's going to be in Article 16, which is going to be changing the children's behavioral health respite home. The next definition is new, and this is going to take the place of what we call now clinical supervision. Okay. Clinical oversight means monitoring the behavioral health services provided by a behavioral health technician to ensure that that BHT is providing the behavioral health services according to the healthcare institution policies and procedures, provide an ongoing review of the BHT skills and knowledge related to the provision of those services, providing guidance to improve the BHT skills and knowledge related to those services, and recommended training to improve the BHT skills and knowledge. Okay. So for a behavioral health technician, they're going to require clinical oversight. Okay. And we're going to talk about what clinical oversight is, because that's going to be a little different. What's changing is what the frequency was and how much time actually had to occur in clinical supervision. Now, a collaborating healthcare institution, this is going to be tied to those two in Article 16. So we won't talk about that. Conspicuously posted means placed at a location that is visible and accessible within the area where the public enters the premises of a healthcare institution. Okay. So that's changed a little bit. That used to just be conspicuously posted, now it tells you where it needs to be located at. Contracted services means medical services, nursing services, health-related services, ancillary services, or environmental services provided according to a documented agreement between the healthcare institution and the person providing those services. Okay? When we're talking contracted services, we're not talking the contracts with you individuals who might be coming into your facilities. Okay? These are just a contractual agreement, so food, cleaning crew, all of that stuff. And you can see, if you've had a chance to look at some of these, that these are the general rules for healthcare institutions. So you're seeing a lot of stuff that is part of what the healthcare institution now entails. In-service education, this is another terminology change. In-service education is basically what training is now. Okay. So in-service education means the organized instruction or information that is related to the physical health or behavioral health services and is provided to a medical staff member, personnel member, employee, or volunteer. Another change is what's called an interval note. An interval note means documentation updating a patient's medical condition after a medical history and physical exam is performed, or a behavioral health issue after an assessment is performed. Okay? And we're going to talk a little more in detail about that once we get into the article. That's going to be a change, it's not highlighted right now, because what Alice is gonna talk about is the quality management plan. She'll go into detail about that. Now, the scope of services. This is a list of the behavioral health services or physical health services of the governing authority of the healthcare institution as designated as being available to a patient at that healthcare institution. Okay, so those of you familiar with the program description, okay, that program description is actually going away. And what you're going to detail to us is what the scope of services are for your facility. Now, as part of the program description, like I said, some of the stuff that was in there, like your administrative hours and your clinical hours and some of that stuff, you're gonna have to put on the application now. Then for your scope of services, you're basically just putting down kind of a list of the behavioral health services and the physical health services, but we just don't want a straight list, okay? So we want a little detail about what it is that you're going to do so that we have some basic kind of understanding of what it is that you're gonna do. However, we're not looking for 40-page documents, but we're not just looking for, 3 services, okay? So, it's kind of a work in progress on how it is that we're gonna be seeing what that documentation looks like. But again, I don't know if Alice talked about this. Part of this was to integrate the physical health services. The other part of doing the new rules was some deregulation. Okay, so we're trying to kind of mitigate those long documents that really, just kind of built up over the last 10 years from the last rule set. So, scope of services, we're still kind of working that in-house on what that's going to look like. So the healthcare institution subclass now is going to be a behavioral health residential facility. Like Alice said, we're no longer going to have the levels when it comes to that. Okay. Whether it be level 2, level 3, or level 4, they're all residential. And as many of you know, a healthcare institution license is required for each healthcare institution. So for every address, there needs to be a license. Okay. Approval of the architectural plans and specifications. Remember, these are general rules. Okay, they're not going to really apply to any of your residentials. So, again, we're in Title IX, Chapter 10, Article 1. When you're looking at your policies and procedures, or when you're looking at any documentation that might be personnel records, any references that you have to anything in Title IX, Chapter 20 are going to be moved. Okay? Title IX, Chapter 20 is basically the approval process for DUI and domestic violence. That's the only thing that's in there. It stops at Article 2. Right? Okay, so there is no Article 3 in Title IX, Chapter 20. So as you go through and look at your policies and figure out what we're going to have to do, just make sure that you understand that most of that's been reviewed. So for the fees, nothing's changed. It's still the $50 application fee, then it's the license fee, and then it's $94 per credit. The renewal is going to be the same kind of process, 60 to 120 days. We know what has to be in that document based on these rules. We just haven't configured that form to kind of match what it is that we need. Now, timeframes have actually decreased a little bit. When it comes to the initial and when it comes to the renewal, the initial went down significantly. So, changes affecting the license, that's still going to be very similar to the way that it was. And then TB, for any of you that may have some multiple subclasses, TB is actually going to be as applicable in each article. So, for whatever article you're in, so we're in Article 7, if it doesn't say that TB tests are needed for both clients and staff, as it's written today, which means if it's not in there, we're not going to do anything with it until we potentially change it by April 1st of next year. Okay, so what we were talking about is some of the stuff that we were thinking, you know, they would go through and kind of add it because it was more like an omission. Their current rules until we potentially tweak anything starting in April or up until April 1st. And then the rest of this is going to go into some of the specifics for some of the medical services that residentials could provide. And now, some of the major changes when it comes to how you define what a paraprofessional and what a technician is. If you're familiar with the current rules, you're aware that there's kind of like a set criteria for paraprofessionals or for technicians and even for professionals. Okay, it says that if you're one of these, so for a technician, if you had a bachelor's in behavioral health, if you had a bachelor's degree in 1 year full-time behavioral health work experience, and that just went down. We're no longer defining it like that. You're defining it. Okay? So that's what Alice was talking about. It's policy driven. You guys decide what a BHT is, what qualifications they have to have, what education they have to have. You do that, and we're going to hold you accountable to that based on your policy. The same is true for a paraprofessional. Okay? And if you look at the definition for a behavioral health professional, this is where it's going to get kind of tricky. Because now that last one's done. You can see as it's written now, it's only folks that are licensed via the Board of Behavioral Health Examiners. Okay? So a psychiatrist, as it's written now, is not a BHP. A psychologist is not a BHP. And the one thing that's changed is an RN with 1 year of full-time behavioral health work experience will now not qualify as BHP. Okay. So, an RN with 1 year of full-time behavioral health work experience used to be defined as behavioral health professional. They no longer meet that definition. Okay. So for the technician part of it and the paraprofessional part of it, you guys are making those determinations. And then for these paraprofessionals, it tells you specifically what happens if they're doing any of the services that are actually licensed under the Board of Behavioral Health Examiners. So for the paraprofessional, you have to delineate the services that they're allowed to provide. And if a behavioral health paraprofessional provides services under the practice of marriage and family therapy, counseling, social work, or the practice of substance abuse, you have to make sure that that paraprofessional is under the supervision of under the supervision. So if a paraprofessional, for whatever reason, is doing any of these services, they have to be underneath the direct supervision of someone who's licensed. Okay? Direct supervision now means sitting in the room. Okay? So, clinical oversight for technicians, direct supervision for paraprofessionals. Okay. Now again, this is specific to providing any service that they're qualified to do. And you get to decide if a paraprofessional is qualified to do this, but you'll see that they're still not allowed to do counseling. You know, it says it there. They have to be under the direct supervision. Now, if they're doing any kind of other service, which a paraprofessional does, so, you know, the general oversight, assistance in the self-administration of medication, that's where you're determining what qualifications are. Okay. And then for BHT, if they're providing any of those services that are licensed under the Board of Behavioral Health Examiners, then you have to delineate the methods used to provide clinical oversight. And then it talks specifically, if you were to provide any clinical oversight electronically, that it has to be a secure connection. And as a paraprofessional, there was no designation of how often or what the frequency of that direct supervision. But in here, for a technician getting the clinical oversight, it has to happen at least once during each 2-week period if the behavioral health technician provides services related to patient care at the healthcare institution during the 2-week period. Okay. So there was no duration. And then this takes care of, you know, if someone's out on leave, if someone's on vacation. There was never any kind of provision for that. If they were full-time, they needed 4 hours. If they were part-time, it was 1 for every 20 hours worked. Okay. You, as the entity now, have to decide what the duration for the direct supervision or the clinical oversight. Okay. And it's based on the scope and extent of the services provided, their acuity, and the number of patients receiving services. So you can see what it's going to look like for your P&Ds. Okay, the whole point was to kind of deregulate, but there's going to be kind of a shift starting in October when we're going to be looking at clinical oversight now, not clinical supervision. We're going to be looking at direct supervision, not clinical supervision. We're going to be talking about orientation, then we're going to talk about the new stuff that's in that scope of services. So there's a fair amount of change, especially for the residentials, just because of the staffing levels that they have. And then the rest of this is going to talk about more kind of a medical component. And again, this has to do with some classes in Article 16, so we're not going to talk about it. You can just highlight it. This was prior to Friday when we found out that they're still in the Now I'll turn it over to Alice.
So let's get in a little bit of the nuts and bolts in Article 7. Back and forth like that. Maybe not. Okay, there are a few additional definitions in here in this section that were not in Article 1. And looking at the supplemental application requirements. Okay. Very similar to what you're used to in the current rules, license capacity, the age of the clients, sorry, of the residents that you will have in the facility. For administration, you're going to establish in writing your scope of services, like Brian stated, your application will be more of a listing of the services, but we are going to want to see more of a description of what those services are. So we will need to designate that in writing. Designating an administrator who has the qualifications, adopting a quality management program, which is a little bit further on down the road. And the administrator is going to ensure that policies and procedures are established, documented, and implemented. A little bit different verbiage. Policies and procedures. Try to think of what you're seeing here in Article 7. These are the rules. These are the rules to play the game. Your policies and procedures are how you're going to, what you're going to do to follow the rules. So, for example, sometimes we go out and we'll see, one of the places, we'll see a lot of cut and paste. And the policy and procedure for something might say, the administrator shall ensure blah, 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 blah. Well, that's just what the rule says, the administrator shall ensure will happen. We're wanting to see what your entity, what your agency's procedure is and what your policy. So let's say, for instance, fingerprinting. Your policy may possibly be, it is the policy of XYZ agency to ensure the health, safety, and welfare of all their clients by requiring all staff to be fingerprinted. That's policy. Tell us what you're going to do. Now your procedure, how are you going to make sure that that happens? It's not a copy of the statute or a copy of the rules that says they must be fingerprinted. How are you going to do it? Upon hire, all staff will have or will be able to obtain a fingerprint clearance card within 7 days. Your file will contain a copy of the application, a copy of the criminal history affidavit. The administrator, program manager, whomever you determine, may contact DPS within 30 days to check on the status of that fingerprint application. What happens if you get a letter back saying that this person can't qualify for a fingerprint application, or a fingerprint clearance card? What are you going to do? So that's what your procedure is. What are you going to do to make sure that this happens? That they're going to have fingerprints and what you're going to do to follow up with that. Okay? So policies and procedures established, documented, and implemented. This is going to include your job descriptions, job duties, orientation and in-service for your personnel members, employees, volunteers, and students. The orientation is going to be what you determine and whom you determine is going to have orientation. So instead of the list that we have currently that lists out all the things that need to be covered in orientation, you're going to determine what needs to be covered in orientation. And honestly, when I've seen a lot of orientations in personnel files, I'll see the things that we require, and then you add it on to that. And that's fine. Whatever you think needs to be in the orientation for your staff. And then which staff needs to have that orientation? Is it the doctor who comes in once a month and checks meds or something along those lines, or is it your everyday direct care staff? You're going to determine that. Also, let's see, I think we talked about in-service education. So your training, 48 hours the first year, 24 hours every year after that. You determine that. Currently, we're telling you how many hours. Now you're going to be telling us how many hours. So we go and review your policies and procedure manual, and then look at your personnel records. And if your policy and procedure manual says that your staff are going to have 92 hours every year, we're going to want to see 92 hours of documented training and education. We're going to say 10 hours a year. That's up to you. CPR and first aid, you're still going to have the same for that. Specific steps and deadlines for a resident to file a complaint. So there's two types of policies and procedures. One is administrative and the other one is service-driven. The first ones were kind of more administrative, orientation, training, personnel records. Now the second one is going to be service-driven. So policies and procedures, we're covering screenings, admissions, assessment, treatment plans, transport, discharge, outings, very, very similar to what you've already developed PMPs for. You're already doing these things. Pet policy. Policies and procedures are reviewed at least once every 2 years and updated as needed. They need to be available to personnel members, employees, volunteers, and students. So you need to make sure that your PMP manual is available to them. Now, what does that mean? Can it be a notebook on the shelf? Can it be on the computer that the staff use to make your progress notes? It just needs to be available. And Brian already did, we have actually a definition of available. If you have 10 or more residents, you will need to designate a clinical director. And the clinical director will provide direction for behavioral health services provided at the facility, and this clinical director is a BHP, behavioral health professional. If you have less than 10 residents, you do not need to identify a clinical director.
Is that at each location or overall?
Per license, because if I remember, every location has its own license.
Thank you.
Administrator will notify the department in writing. Here's your IRs, your incident reports. They're gonna go down for us. Your contractual responsibilities and funding responsibilities, we have no control over that. However, for OVHL, the two things that you are going to report to us are gonna be a resident's death within 1 day, and then the self-injury or an accident that requires medical attention within 2 days. So we're not gonna be seeing AWOLs. You're not gonna be calling us 3, 4, 5, 6, 7 times a week with a list of incident reports to report to us. We don't need that. You can call, ask questions, call, say hi, but you don't need to be calling in your incident reports. All can be done in writing. Also, as far as incidents here, abuse, neglect, or exploitation of a resident, that is alleged or suspected to have occurred before they were admitted or while they were not on the premises receiving services from this facility's employee or personnel member. What are you going to do if you suspect abuse, neglect, or exploitation? You're going to contact for children of the age of 18, CPS, law enforcement. For adults, you're going to contact APS and law enforcement. So G is about if this happens, say this happened 4 years ago and this client's passed and they divulge it, say during a counseling session or through an assessment. It didn't happen there, you only need to follow these steps. Now H, if abuse, neglect, or exploitation of a resident or alleged or suspected to have occurred on the premises or while they're receiving services from your agency, from your staff, first thing you're going to do is you're going to take immediate action to stop it. So you will stop the alleged suspected abuse, neglect, or exploitation, and then report it same way, APS or CPS and law enforcement, and then document the information in a report and maintain that documentation for 12 months. You're also going to investigate what happened and develop a report within 48 hours. And all the information that's included in here, date, time, description, witnesses, actions taken. And then that investigation that you've written, you'll submit a copy of it to the department, to OVHL, within 10 working days after submitting the report as referenced above in H2, and then maintain a copy of that investigation for up to 12 months. For 12 months, I'm sorry, not one, for 12 months. Okay, so if it occurs on your watch, you have more responsibilities that you need to take care of, okay? If it happened before, they were involved with you, then you just need to make those declarations. Administrator, let's see. Establish and document the criteria for determining a resident's absence when it's unauthorized. AWOL, you're going to determine that criteria. And then you will submit a written report within an hour for a resident who is less than 18 to their parent or guardian, or if applicable to the court. Doesn't say you need to submit a report to us. You're going to develop the criteria to determine when a client is AWOL, and then maintain a written log of unauthorized absences for 2 years from the date of that resident's absence, which includes, again, the following information, name, date. Okay, so no longer you're going to be calling in or submitting IRs for AWOLs, but you do need to track it. And part of that is because it's going to be evaluated by you, the agency, and whatever actions that you're taking on how you're going to hopefully keep that from occurring in the future is going to be part of your quality management plan. The postings got a little bit shorter. Basically, I believe it's the list that has the addresses and phone numbers is the only thing. Like Brian said, it does need to be conspicuously posted on the premises. One caveat, let's see, does it say in here? If you have evacuation drills, no, I'm sorry, not evacuation drills, evacuation plans, the maps, you can still put those up throughout the house. That's not something that's going to be conspicuously posted in the front wall. You need it back where it is needed. Okay, this is something new. If the administrator determines that a resident is incapable of handling their financial affairs, you're going to need to notify that resident's representative or contact a public fiduciary or trust officer, and then maintain documentation of that notification. Okay, so if you're finding that they're not able to manage their affairs, you need to step in and get some assistance. That doesn't mean that you step in and you become their guardian, or you become the public fiduciary, or you handle all their financial or any type of needs. It means that you need to step in and try to assist that family member, help for that client. The quality management plan, when we refer to the website, that there are additional trainings and PowerPoints on there, this is listed on there, so feel free to go in and take a look at that so you can have more of an idea of the quality management plan. This is more going to be for you if you are recognizing an issue that you need to deal with. Say it's AWOLs. You will sit down and work on that, and that could be part of your quality management plan. How are we going to decrease the amount of AWOLs that occur on our night shift? Okay. The other thing is when we're out and we're looking at documentation, we might say, you know, there seems to be a lot of AWOLs between 2 a.m. and 6 a.m. So we may identify an issue. How have you responded to that? Well, let me pull out my quality management plan. Let me show you what we've been doing about that. So you're aware of it. You know what you're doing about it. And so you're kind of taking an extra step forward to work on that. So you will need to maintain, you'll establish and maintain your quality management plan, and then keep that on site. Contracted services, again, like Brian said, who you contract with. You contract with the transportation agency, discount cab, something like that, food service, pest control, cleaning crew, anything along those lines. That's your contracted services in 705. Okay, personnel. Personnel members at least 21, employees 18, student is 18, and a volunteer is 21. You're going to be determining the skills and knowledge, specific skills and knowledge necessary for them to do their job as per the job description that you developed for them. And you will determine the type and duration of education that may allow them to acquire the specific skills and knowledge so that you can place them in the appropriate title and position. Personnel members' skills and knowledge are verified and documented before they provide health services or behavioral services, and according to your policies and procedures. So if you remember back in R920-204F, there was a list of 20-some things that need to be reviewed, and then G was how are you going to verify it? Is it going to be through a written exam? Will it be visual or verbal? You're going to determine that. This is kind of taking the place of that 204F. In D, it's talking about the written plan to provide orientation, again, specific to the duties of that person. We talked a little bit about that. You're going to determine what needs to be covered, how much, how long, who needs to have that information. A personnel member, employee, volunteer, or student who has direct interaction with a resident provides evidence of freedom from infectious tuberculosis as specified in R910-112. So your direct staff are going to need to provide freedom of TB. In F, it discusses what needs to be kept in the employee's record, personnel record. In I, this kind of breaks it down like we were saying before. We're no longer a 2 and a 3. We need to have specific people on call or on site, whether it's a medical practitioner or an RN. This kind of breaks it down a little bit, takes that out of it, and says this is what needs to be for just residential facilities, period. Behavioral health professional is present or on call. A nurse is present or on call. So it used to just be for level 2s, and now it's across the board. Okay, admissions and assessments. Okay, medical practitioner will perform a medical history and physical exam, or a registered nurse perform a nursing exam on a resident within 30 calendar days before admission or 7 calendar days after admission. In the past, we said if they've had a physical in the last 12 months, you can use that after your medical professional has reviewed it. Now it's 30 days. You only use one that's been within 30 days. If the medical practitioner performs the history or physical exam, or the nurse performs the assessment, the medical practitioner will enter an interval note, again, going back to the definition, and the nurse enters a progress note in the record at the time of the admission. So if you've done the assessment, you've done the physical, you need to make sure it's noted in the medical record. Assessment is completed before treatment is initiated. Everything that needs to be in an assessment, presenting issues, no real changes here, substance abuse history, co-occurring disorder, medical condition, legal history, criminal justice, family history. None of this has really changed. Okay. What will be included in this assessment, what's important here is B2. The physical health services or ancillary services that will be provided to the resident until the resident's treatment plan is completed. You're not going to be required to do an initial treatment plan. Your initial treatment plan, if you will, is actually included in the assessment. This part right here is saying that in your assessment, you're going to be describing what treatments, what services is going to be offered to them. So this will be the beginnings of your treatment plan. Also, for a resident's assessment, a request for participation is made to the resident or the representatives. The opportunity is provided to them. And what's changed here is that documentation must be there that they have been offered the opportunity to participate. Residential facility, they'll be providing respite services. This is still more fun. Okay, so this is just respite services, okay. So providing respite services upon admission, a medical history or physical exam is performed or dated within the previous 12 months. So remember, 12 months for respite, 30 days for your general residence. Treatment plan is developed. There are some restrictions to common area as far as square footage. There needs to be at least additional 25 square feet. The toilets, sinks have changed. They're outlined in here rather than these be at least one working toilet that flushes and one sink with running water for every 10 residents. Don't get this confused. This is section E3. This is for respite only. Don't get this part confused with the number of working toilets and showers and sinks with the general physical plant standards. Okay, that's going to be a little bit farther on down in this Article 7. Okay, this is only for having respite. Alrighty, treatment plan. So treatment plan is developed and implemented for each resident based on the assessment completed by a behavioral health professional or a behavioral health technician who is under the clinical oversight of a BHP. Your BHTs can still do treatment plans. They need to have clinical oversight from your BHP. That is really not a change. It's just kind of the words, okay? And it needs to be completed before a resident receives any physical health services or behavioral health services or within 48 hours after the assessment is completed. It's documented and in the record within 48 hours after the resident first receives a physical health service or a behavioral health service. I believe previously it was like 7 days, so the time frames has been cut quite short. Same things it needs to include that you're used to already, is there any issues? If the treatment plan was completed by a BHT, reviewed and signed by a BHP within 24 hours after completion of the treatment plan. So that is not 24 hours in addition to having it put into the record in 48 hours. You don't get 72 hours, it's a total time frame of 48 hours. So you have 24 hours to get your BHP to review a treatment plan written by a BHT. And then just an additional 24 hours to get that. Discharge. Changes in discharge summary is now needs to be in the file within 10 working days, not 15. So make sure your discharge summaries are in the records within 10 days. Transport and transfer. Basically, simple part of it is transporting is you're going someplace and coming back. Transferring, you're transferring them out of your facility to another facility. Resident rights. You're familiar with these, you have these posted. It may look a little bit shorter in here. It's not, it's just that they have been kind of combined a little bit on some of the lines. So it's a little bit more streamlined on what those are, but the resident rights haven't changed. Medical records. Okay. All right, so Brian's going to take over.
Okay, for medical, the medical records, not a whole lot's changed in here. However, there has been documentation finally to put the electronic record stuff. So, as part of that, that's really the only thing that's changed when it comes to that. So you just have to make sure there are safeguards to prevent unauthorized access, and there has to be the date timestamp for the computers and terminals. So the stuff that Alice just talked about with the interval notes, that's one of those few things that will change. And then the documentation specific for those interval notes, depending on what's happening or progress. And again, we're looking at integrated health. Okay? So depending on what kind of services you're doing, what's applicable for any of this stuff now needs to be in the record. Resident outings, you're gonna see kind of the same stuff with that, with the documentation and all of that stuff. You still need to make sure that there's a first aid kit in there, however, no longer defined what's in the first aid kit. Okay. So we're not gonna go out and look and tear open the first aid kit that's in each of the vans, but we are gonna make sure you have one. The other thing with an outing now that's changed is that you actually have to have one additional personnel member on it. Okay, so there has to be two personnel members now on an outing. And keep in mind the definition of an outing hasn't changed. That's if you're providing any kind of ancillary service that's outside of your program for longer than 4 hours. Resident timeout is similar to what timeout was. Physical health services. This is where kind of the basics for the personal care come into play. So if you choose to do personal care within your integrated residential, you have to have documentation of completion of caregiver training program that complies with our 433-702. And residents receive personal care services according to our 813. Okay. If you're going to be basically like a hands-on, where you're going to be helping them with those personal care services, which is kind of a bridge now with integrated health for behavioral health licensing and assisted living licensing. Okay, in the past it used to be one or the other. Now this is kind of, we're starting to kind of integrate all of that stuff. So if you are helping them with those activities of daily living, all of that stuff, then you have to have this training. I believe the training is,
I believe it's 140 hours.
104.
104. Okay.
It's a certification, and you have to take a written exam for that certification.
But once you have that, then you have it. So that's where the documentation, and we're seeing that you're doing kind of the integrated health components of it, and we would expect to see that documentation in the personnel members record. Okay. Now for the behavioral health services, again, we talked about the definition of what the residential facility is. And part of it is that you're still doing what you currently are doing, which is continuous protective oversight of those clients on top of the services that you're doing. Okay. Now, as part of this, for the behavioral health services, we'd be looking at what your scope of services is, to make sure that you're not doing anything that may not be on the application, or that you've defined is not part of your scope of services. Now, like I said before, shall ensure that counseling is provided according to the frequency numbers identified on the treatment plan, and is provided by a PHP or PhD. And if you're working with kids, the same thing that was in there, in Article 4 was this, there is an opportunity to continue to provide services to that individual should they turn 18 if they meet a certain criteria. But then again, that poses some challenges of the way that you have to configure your residential to make sure that you're not staying in a room with children, with adults. That piece is still there so that they can continue to get the services if they in school. Emergency safety response, basically the same as it was. The one thing that came out of that was the nationally recognized component of it. Now they just have to be trained for the use of emergency safety response. So you, as a policy, get to decide what it is you're going to do if you're going to do ESR and what your training protocol is going to be. Again, it's still the same. Discontinue at the earliest possible time, no longer than 5 minutes. And then it talks about how you have to document it. And again, this is going to be part of quality management. Okay, so something happened, so this is where you're going to do some additional follow-up and figure out if we mitigated by having to do the ESR by doing something else. Now, the training has got to be in crisis intervention, and it's got to include techniques to identify personnel member present behaviors, events, environmental factors that may trigger the ESR, the use of non-physical intervention skills such as de-escalation, mediation, conflict resolution, active listening, and then the safe use and the ability to recognize and respond to signs of physical distress in a client who is receiving an emergency safety response. Okay, that part's new. So part of the training is that your staff have to understand if they're causing an issue and causing distress, then how are you going to follow up with it? Now I'm just going to touch on the Act 4 behavioral health care programs. We only have one in the state that have to be deemed. And these are kind of programs that was created 3 years ago, 4 years ago. There's just one program, and just the way that the services are, they have, I believe, a clinic in East Phoenix, but they're an outdoor program, so they'll go out into the wilderness, and they might be out there for 15 days. So they needed that physical building to be licensed, but they do a lot of that stuff in the wilderness. So that's just part of what it is that their program is. Should you choose to ever do anything like that, just understand there are licensure requirements for it.
Now you have to be accredited.
Medication services, if you're familiar with the current rules, if you do medication services, you're in Article 3, and if you do assistance in the self-administration of medication, you're in 408. These are combined now. They're in 718, and they're called medication services. So you'll find both of those now in medication services. And not a lot's changed with it. Medication services what was medication services is now medication administration. And then if you scroll down, here's the requirements for assistance. You have to make sure training for personnel other than the medical practitioner or registered nurse is done, and that's going to be pretty much the same, except we're not identifying those skill sets. In 408, there were those 9 or 10 skills and knowledge that had to be verified. Now you're identifying that, or you're the folks that are providing that assistance in the self-administration medication training are doing. Okay. The other thing that's changed is the ongoing training. Okay. If you're familiar, it was that you got the initial training to do it, then you had to have training every 12 months following it. That's no longer a requirement. Okay. Now remember, these are the minimum rules. So policy, however you determine it, if you're going to go above that, that's up to you. The administrator shall ensure that their current drug reference guide is available toxicology reference book is available. Okay. So on the premises, per se, it's available. So if you have a central intranet site and you put that information on there, it's just got to be available. And then for the integrated health, this is primarily more for like an outpatient clinic. That if you were to have a pharmacy and provide pharmaceutical services on site, you need to make sure that there's a copy of the license that's available to us. We don't have jurisdiction over the pharmacy. The folks that license pharmacies do. But if it's in the integrated health component of it, we just want to make sure that the pharmacy is licensed. It talks about medication. Now it kind of details how the medication has to be stored. Okay. There is a separate, medication is stored at the behavioral health residential facility. An administrator shall ensure that there is a separate room, closet, or self-contained unit used for medication storage that includes a lockable door. If medication is stored in a separate room or closet, a locked cabinet is used for medication storage. Medication is stored according to the instructions, and then policies and procedures have to be developed for how you're going to store it, inventory it, dispense it if applicable, how you're going to discard it, if there's a medication recall, and then storing, inventorying, dispensing the controlled medications. And here's where it talks about a medication error on what you're going to do. Because remember, you're not going to necessarily report that to us. Now, other entities might require it, but okay. Food services, 10 or more residents. If you were in the inpatient training, now it's every inpatient needs to. But for the residentials, it's still the more than 10 that you have to have a food establishment license. Okay. So don't get that confused. There are two sets of rules. One subclass requires it for everybody. The residential says for 10, more than 10, so 11. You have to have a registered dietitian who's employed full-time, part-time, or as a consultant. And if the registered dietitian is not employed full-time and the individual is designated as the director of food services who consults with the dietitian as often as necessary to meet the nutritional needs of the residents. And that part that's changed is that that dietitian doesn't need to review the menu every 12 months. And then this part just talks about the specifics. Talks about how where stuff has to be heated to, what it had to be cooled to. They have the emergency and safety standards. Except for that outdoor behavioral health agency provided by behavioral health residential facility, the administrator shall ensure that behavioral health residential facility has a fire alarm installed according to the National Fire Protection Association, per their code incorporated by reference in R91-412, and a sprinkler system installed according to that. Or an alternative method to ensure that the resident safety is documented and approved by the local jurisdiction. Okay. Now, this is probably one of the biggest changes for the residentials. If you remember, if you went 1 to 3, you had specifics you had to follow. If you went 4 to 8, there were specifics you had to follow. And if you're 9 or more, then you had to go to a sprinkler system. Okay. This is saying now, you either have a sprinkler system or the local fire jurisdiction has to okay what you currently have. Okay. Now, depending on your jurisdiction, there might be some changes coming when you do your renewals after October 1st. Okay. Now, the good thing is most of the cities now are using the national codes. So in the past, it used to be one municipality would say this, the other municipality would say this, and they could be within a half mile of each other, okay? Now, it's either sprinkler system or on that fire inspection report, it has to say the jurisdiction approves the licensee or whatever for 5 beds, whatever it is. Okay. So I would encourage you that as you're coming up to your next rounds of renewals after October 1st, is that you probably might want to communicate with your fire inspection, whatever municipality it is, just so that you don't kind of get stuck or caught in that catch-22 where you have 9, but they're only going to approve you for 8. Okay. That's where this is a very frequently asked question. Okay. But the rule's pretty clear. It's either a sprinkler system incorporated by the National Fire Protection Association or approval by a local jurisdiction. Now, for the residential facility, you have to do an evacuation drill for employees and residents on the premises. Is conducted at least once every 3 months on each shift. For the residentials, that's the one thing that is pretty consistent. We just don't call it a fire drill. It's just an evacuation drill. And down here, it tells you where to document it. You still have to maintain it for 12 months. For you, it's still evacuation paths conspicuously posted on each hallway of each floor of the facility. Now, in the past, we used to say that a disaster, you just have to have a disaster plan. Now, we talk more about your disaster plan and what it has to include. Okay, so this is one of the few times where we actually are more prescriptive than we were in other rules. One of the reasons that they decided to do that is because we've had, I think, every office on this floor has had issues where we had to move folks because of the wildfires. Okay, and then they have to set up the commands here, and we have to know how close those fires are, where we can move folks. I mean, we've had fires go up to the gate, the back fence of some of our agencies. And we always kind of tell the story, you know, you have to think about a disaster plan and what it is that you're going to do when you don't think it's going to work. Let me explain. So, say you have a fire, you're 10 beds. Well, what are you going to do if there's a fire? We'll hop in the van and we'll go to this hotel and we'll kind of set up there and then we'll do whatever. Okay? Van's out of gas. The fire or the gas station is closed and the hotel is full. Now what do you do? That's how you have to be thinking about this. Don't just think that hotel or that motel or wherever I can stage if I need to get out. Think about it in terms of what if that doesn't work. And when you think about it like that, your disaster plan will be much more of a meaningful document rather than just something you're going to follow, you're going to throw, or something that you're just pulling out for OBHL when OBHL shows up. Okay. Environmental standards. There's a few additions when it comes to this stuff. You have to have a pest control program that's implemented and documented. If you have equipment, and again, this is kind of integrated health, you have to make sure that equipment is tested and calibrated, used according to manufacturer recommendations, and documentation of that equipment testing. Heating and cooling, these numbers are a little different. I think it was whatever it was. They've changed. I think the range is a little narrow. Hot water It used to be 90 to 120, now it's 95 to 120. And again, keep in mind, you know, it may not be just right at October 1st. We are going to see some integrated health. We're going to see the personal care. So in behavioral health licensed homes, we're going to see oxygen tanks. We're going to see folks who are qualified to do the personal care stuff. So there'll be additional equipment. So you're going to have to come up with plans if you choose to do that on how you're maintaining that equipment, how you're making sure all of that stuff. It talks if you're using a non-municipal water source, what kind of testing you have to do, and if you use a non-municipal sewage system, what it is that you have to follow. Now, for any of you that have swimming pools, this will be new. Any day that a resident uses the swimming pool, you have to conduct tests on it. Now, that can be kind of your basic check of that. But it's only for each day that a resident uses it. And you have to maintain a log of what the water quality was at least 12 months after the date of the test. You have to make sure that there's one personnel member with CPR present, and at least two if there are two or more residents in the pool area. Physical plant standards, a lot of this is going to be pretty much the same as it is. It's all just in one area. Okay, for residential, it's still 60 square feet. One thing that's changed is, if you remember, your maximum capacity for a room was 4. Now, if you have a room where you can have 60 square feet for every client, excluding the closet space, you can now go up to 8. Okay. So that's a pretty big change. However, remember, the stricter rule trumps when it comes to the fire inspection. They may come in and say, you know, okay. But trust me, I've been in some rooms, especially down in the Tucson area, where you could put 12 people in a room that was that big. But our maximum bed count for a room was 4 right now. So that's going up to 8 as long as there's 60 square feet, excluding the closet. The bed and all of that stuff is going to be the same. Now, I don't know if we have any level 4s in here, but if we do, a behavioral health residential facility that was licensed as a level 4 transitional before October 1st may continue to use a shared bedroom that provides at least 40 square feet of floor space, not including a closet for each individual occupying the shared bedroom. If there is modification to the shared bedroom, the behavioral health residential facility shall comply with the requirements in EHG. Okay. If you think about like a level 4, our level 4s are kind of transitional living, so they can be like a halfway house. So we have kind of places where folks are transitioning out of the federal prison system, some that are kind of substance abuse driven. So think of that as kind of transitional living. So that's what was decided for the 40 square feet, just because it's transitional living. They probably aren't in that room all that often, kind of unlike a behavioral health residential facility where there's potential that they're actually, well, not the potential, that they're getting services, so they're going to be much more in that area. And that's it. Now, I want to throw something out, and I don't know if we can talk about this. Had to do with TB tests. Okay, you saw TB tests for staff. did you see TB test requirements? Okay, that's what I'm telling you. We kind of thought that there were some omissions that we were gonna put in there. However, last Friday, we found out that these are gonna be the current rules at least until April 2014. So, remember, these are the minimum rules. Now, you guys have to decide how you're going to proceed.